I hope for this to sort of be a discussion. I'm going to talk about 3 cases and use that to sort of go over some of the issues that come up with return to play with spinal conditions. And for me, there are 3 cases that I had seen in the last 2 years, and they sort of, I wouldn't say changed how I approach these patients, but made me think about different things. I have no disclosures or conflicts of interest. These are the objectives, basically discussing some of the clinical factors involved in return to play decisions when it comes to spinal conditions, discuss the clinical guidelines available or lack of, and then highlight the patient factors that affect return to play, which, in my opinion, I think are the most important things. So the first case, this one is one I saw about 2 years ago. He's a 14-year-old football player who lived in Moses Lake, and I actually saw them at the time I was working at a practice that had an office in Tacoma, so that's where I saw him. But 2 months to seeing me, he was involved in a motor vehicle accident. He was a passenger. Their vehicle was rear-ended by a semi-truck. He was not knocked out, but his head impacted the headrest behind. The vehicle was a total loss. He went to the emergency room. They did scans. Everything was negative, and he was released 1 week later. When I saw him, he was complaining of 5 out of 10 pain. It was constant. It was in the midline of his neck. It was achy, crampy, and tight, improved with heat. He'd been seeing a chiropractor in his hometown. He had no night pain, no paresthesias, no upper extremity weakness. Essentially, his main complaint was this pain and a decreased range of motion and tightness. But it was the fall and football season had started, so he was attempting to play. They were holding him out of contact, but he was doing all of the conditioning, and he was trying to do it with his helmet on and having a lot of issues. His exam, he had full range of motion, but it was painful. This is his x-ray there at AP. He had some spinous process tenderness, positive Sperlings. Sensation was normal, and there wasn't really any neurological issues. These x-rays were taken 2 months after the motor vehicle accident. He still had straightening of the cervical lordosis. He had that mild S-shaped curve from the last image. The radiologist read it as grade 1 anterolesthesis at C2, C3, and C3, C4, and then sort of qualified it that it could be positional, but he didn't have any fractures. So I ordered an MRI. This showed straightening again of the cervical lordosis. He had mild posterior lateral disc bulges at C3, C4, and C4, C5, with mild encroachment to the right neural foramen without nerve impingement. But then he had this subtle syrinx in the cervical cord measuring 1.3 millimeters at C7, T1. You can see those there, just that little white streak and dot. And so his dad's question to me was, can he play football? He was already practicing, and they wanted to know if it was fine for him. And really, they didn't really want to know if it was fine. They wanted me to give them the okay that he could continue doing what he was doing and start doing contact. And so just kind of briefly, cervical spine injuries in sports. Athletes sustain around 10% of the 10,000 cervical spine cord injuries that occur each year. Obviously, contact sports are more of a risk for this, especially when it comes to things like fractures. Also, repetitive motion sports, so things like gymnastics, diving, are at risk for sort of stress injuries of these areas. 10 to 15% of football players may experience a soft tissue or neurologic injury. This is looking at sort of more impact injuries. And then there are some studies that say in football players, things like stingers and burners or these neuropraxic injuries, the incidence of these can be upwards of 50%. So obviously in contact sports, it's a big deal. As far as the biomechanics, as we all know, cervical lordosis is important in helping dissipate some of the forces that can impact the spine, especially if you're axially loading. This has sort of been a popular topic with the NFL and concussions and heads-up tackling and whether or not athletes are allowed to lead with their head and some of the consequences of that. But essentially, if you lose that lordosis, you're essentially having a spinal stenosis or functional stenosis if your head is in flexion or extension, or if you're axially loading while you're tackling someone. And so that's where some of these guidelines essentially come from. And so I'm going to kind of briefly go through this. They're based on expert opinion. It's hard to do a randomized, double-blinded control study looking at some of these issues. And so the general principles are athletes should have full and pain-free range of motion. They should have a neurologic exam. They should have no unstable bony or ligamentous injury, and then they should have that normal lordotic curvature. Congenitally, these are on the right there, according to these experts, these are conditions in which an athlete is essentially cleared to play. Congenital, if you have spina bifida occulta or type 2 Klippel Feel at C3 below, which is basically a central canal stenosis. Without symptoms, you're free to play contact sports. Developmental issues, so Torf-Pavlov ratio of less than 0.8, which is essentially cervical stenosis. It's not really severe and asymptomatic. Non-displaced stable fractures that have healed. A clay shoveler's fracture you can play with. Healed herniated nucleus pulposus you can play with. A one-level fusion you can play with. Single or multi-level posterior cervical laminoforaminotomies, again, healed and asymptomatic, you can play with. Less than 3 episodes of neuropraxia lasting less than 24 hours with full cervical range of motion and a normal exam. And again, some of these, when I read them and I think about if athletes were actually in this position, I think there would be a lot of discussion before we were allowing someone to play that had 2 of these episodes, even if they were less than 24 hours and their exam is normal. But according to the experts, they can play without issues. And then 1 episode of transient quadriparesis with full cervical range of motion, essentially a normal exam. It was one time and it happened and it resolved. Again, I think that could technically be debatable. The relative contraindications, and I think this is where a lot of the sort of give and take comes in, are athletes that sort of have some of the conditions on that previous slide, but now they may have some symptoms. So a Torf-Pavlov ratio of less than 0.8, so someone with cervical spinal stenosis and or sensory neuropraxia. Previous episodes of neuropraxia, if they've had a 3rd episode, quadriparesis that lasts longer than 24 hours but then resolves. 2 or 3 level fusion, excluding a posterior segmental lateral mass screw fixation. And that's not really something I'm too familiar with, and I think you surgeons might be able to speak on that. Healed but displaced stable fracture from C3 to C7 at the posterior ring or compression fracture. If it's upper level, it's healed and non-displaced. Instability of less than 3.5 millimeters or 11 degrees. And then a healed herniated nucleus pulposus with residual facet instability. These conditions would essentially be a risk-benefit discussion in looking at the level of the athlete, what is their incentive to play, why are they wanting to play, versus the risk of catastrophic injury. And then the absolute contraindications, congenital ones, really anything at C1 or C2, a Klippel Feel anomaly, which is essentially congenital cervical stenosis. If you have the syndrome, I don't think you would be good at sports, and so these are people that sort of on that spectrum. Interestingly, that picture on the artist rendering on the right, if with that thick neck, I think a lot of football players just look like that. And so, sometimes it might be, maybe we need to get imaging if, on these athletes. Developmental issues, acute fractures, I'm not going to go through all of these, but really these are, pretty major, severe injuries to the spine or upper level fusions that are contraindications to participate or lead to athletes retiring. I think Cam Chancellor is retired, Cliff Averill retired this year. Peyton Manning ended up playing after his neck fusion, and I think because he was a quarterback and he wasn't tackling, but essentially he was forced to retire because of these types of things. So for just an abnormal MRI, which is more related to the first case I presented, this is sort of really, really expert opinion. The theory, again, is a functional stenosis. So that if you have any subtle or mild abnormality on MRI, the thought is that when these athletes are in positions of flexion or extension of their neck, they are essentially in a sort of transitional stenosis. And so it may not be safe for them to play while these abnormalities are present because the changes to their spinal cord essentially put them in a position where they're having stenosis. And so it's kind of, I don't know if it's easy to see, but for syringomyelia, essentially if they are asymptomatic, there's no other findings, and the syringomyelia is benign, they're given the okay to play. For some of these other conditions, spinal cysts, tethered spinal cord, this group in paper, essentially what they said is send them to a surgeon, and if the surgeon's cool with it, then they can play. So that's kind of on you guys. The discussion for a lot of these is going to be, again, if your exam is normal, and this is the only abnormal finding is an MRI finding of that's subtle, is timing. Do we wait? Do we get more imaging? And these are discussions that I think are different between every physician and every patient, depending on what their goals are and those sorts of things. So with this case, after this visit, and we went over the MRI, they essentially never came back. When they went back home, I don't know what happened. And so for this talk, I actually called his mom and said, I'm giving a presentation. I kind of want to know what happened. And so for that fall, he sat out the rest of the year because he was still having pain, and then sat out the next year because he was still having pain, and then went back and played this past fall. He played offensive and defensive line without any issues. That was what his mom said. And for me, this is really sort of the theme of this talk, is that a lot of times with these issues, they're out for an extended period of time and they just sort of disappear. And I don't know if he saw a physician before he went back to play. I don't know if they had discussions about his imaging and considered getting additional imaging. But it sounds like it worked out for him, at least initially. This was a case that I was presented by Dr. Robert Cantu at the American College of Sports Medicine conference that I went to a few years ago. It was a 16-year-old linebacker. He had 2 minutes of quadriplegia after a head-up tackle. His motor and sensory symptoms cleared after 10 minutes, and then had a painful neck for 3 weeks. 2 weeks later, after his neck pain resolved and he had full range of motion, he went back and played his junior year, and then played the next year, senior year of high school, sort of with neck tightness and occasional pain. But then when he got to college, played football freshman year, first scrimmage, he was rendered a quadriplegic after making a heads-up tackle. And so I want to play this video. This was off of ESPN, and the one thing I want you to take note is just how they describe how this athlete played, his style of play, and sort of what you think might have been his issues before he got injured. So hopefully there's sound.
Lee is coming to help.
Okay. So nothing's happening.
Can you activate the video in the back? As we're waiting for the video, Rod,
Trying to get the video to go.
Yeah.
let's go back quickly, if I may, Ben.
So we see these syrinx formations quite a bit as an incidental finding. In the surrounding of a young athlete, is this something that is traumatic or is this truly just incidental?
I mean, I think it's more incidental. We often, you can see it on a cervical MRI to see if they have a Chiari or not. But I think I see a lot of these where they get diagnosed, and these are just congenital, I think. Very rarely do you get a Chiari or something like that. Usually, and the Chiaris are very, because actually Ed Oldfield described it, there's a disruption in the central canal and the subarachnoid space. So they develop really distinctly different, and the imaging characteristics are different, right, Justin?
Yes, I agree.
So, yeah.
This usually we describe as.
I can just play this from the back computer and then I'll have that play. If we want to do that really quick.
Yeah, if you can do that.
Just bend it over
Instead of calling it a syrinx.
Just pull it up and we'll just play it.
Okay.
All right.
He's going to try to get it to play from the back. Apparently, there's no sound.
Justin, That was important. Can you say that one more time so that we can hear?
We're just talking about syrinxes. And in terms of radiologic diagnosis, typically if we see a prominent high T2 signal or fluid signal in the central cord and it's less than 2 millimeters, we'll just say there's a prominent central canal. We look, but we believe it's usually incidental.
The morning routine takes about 2 hours. That's not enough time for pity.
I know in my position people are going to feel sorry for me. I hate it, but I can't feel sorry for myself.
For all that's changed in Ben Abercrombie's life, one love hasn't. I'm going to say a word to you. Football.
I love football. Let me tell you. I mean, just everything football's done for me.
From the moment he stepped on a football field in Hoover, Alabama, Ben's mission was clear.
I think it was 4th grade, we let him play tackle finally, and he was thrilled. He came home from the first practice and just said, "That was awesome."
I remember him tackling a kid over on the sideline by us. Just destroyed him over there and knocked the kid's breath out. He loved making the big hit.
Growing into an all-state baseball and football player and a standout student, he chose a college as much as a team.
Really? You know, my son's going to go play, college football at Harvard. We live in Hoover, Alabama,
You just saw this kid who just flew around like a human missile. In terms of physicality, just in terms of having that edge, he just had it.
In his first preseason camp for the Crimson, Ben made an instant impression and got a quick nickname.
It's like the 3rd week of camp. In the middle of the practice, tight end ran his route, but he was overthrown a little bit. Ben dives and catches it, like diving catch, basket catch, and lands on the ground. Everyone goes nuts. And that's when he earned his nickname, Badger Crombie.
I said, "You fly around like a badger, just like a madman." I said, "Ben, you're going to make an impact. You're going to play this year."
For the 2017 season opener at Rhode Island, Ben was the only freshman on defense to make the trip.
I actually tore my hamstring on the opening kickoff. And Ben, as a freshman, and I'm thinking he's going to be rattled, like he's not ready to go in. He walks over to me, looks at me, slaps me on the leg, and goes, "Hey, I got you."
I really don't know what I was expecting. I was just trying to take in the moment. It's my time to play, my time to go.
It happened right in front of me. They had a big 6'4" wide receiver. He goes up to get a ball right on the sideline. Ben comes up to hit him.
That was his first collegiate tackle, and we were like, Ben just lit this kid up. And the kid hit the ground hard, Ben hit the ground, and when Ben hit the ground, his body went stiff. And everyone kind of got quiet at that point.
I knew something was very wrong. It like he was frozen.
We were just looking at the TV going, "Move, please move. God, move him."
The hit broke Ben's neck and compressed his spinal cord. His C3 vertebra was dislocated, the C4 fractured.
You tell me when you're high enough to eat.
14 months after the injury, he cannot walk. He cannot breathe without a ventilator. The signals from his brain do not reach his body.
You depend on another person for pretty much everything in your life now. And I'm still hoping they'll change.
Let's go back first. Ready? And we're back. 1, 2, 3, 4, 5, and we're up.
He got interrupted on his journey of going to college, and it just stopped. This is the first step to get back.
All right, you can go ahead and stop it. All right. All right, so for me, when I see that and I think about, these issues, the way he was playing, my opinion is that he likely had other injuries to his neck and spine before this specific tackle, just in the way they described how he played. If you go through high school football, he started when he was in fourth grade, and you play that way over time, and it's possible that he didn't, but I find it hard to believe that there wasn't something already sort of brewing before that specific hit. And so that's one of the main takeaways for me is with return to play with cervical spine injuries is really knowing that history, and that involves coordinating with other providers that have taken care of these athletes before you and potentially after you, like when they get to college or get to the next level. And then with each of these situation, it really is an individualized discussion. How did they get hurt? How long were they out for? Were they symptomatic? What does their imaging show? Is it something that's thought to be just benign? What's their position? Looking at someone who's a defensive player versus a quarterback. What sport? How long it took their symptoms to resolve. And when you sort of take into consideration all these things, it is really hard to have sort of this is what you should do. These are the guidelines for this specific situation. Because it's different for every athlete and different for every family, and really with the comfort of the physicians and the community that you're practicing in. It's like two computers. The second case is a 15-year-old male football player and wrestler, and I'm going to try to get through these quickly. He came in for thoracic back pain that he'd been having for around 4 or 5 months. The onset was insidious, but it was during football season. He can't remember a specific play where he got hurt, but he essentially played the whole year with this sort of underlying discomfort. After football season ended, he transitioned to wrestling. He didn't take any time off, but during a match, while he was essentially slamming an opponent to the ground, he twisted his back and his pain worsened. He presented to me with 7 out of 10 pain. It was achy and stabbing with some tingling and tight, but mostly in the thoracic spine region. He did have pain at night that wasn't allowing him to sleep. His symptoms were worsened when he was laying flat and he couldn't lift any objects. He was actually sent to me by a chiropractor, and he said that was helpful, but it was temporary. On exam, he had a normal gait. He did have that tenderness, but otherwise, everything else was normal. Full range of motion, his strength was good, and he had normal sensory testing. I ordered an MRI because of the night pain and because of the length of symptoms that he was having. And so this is his MRI. Again, thoracic syringohydromyelin is how the radiologist described it, with focal enlargement of the central canal from the lower T7 through mid T8 levels. And then he also had a synovial cyst at the right 8th costotransverse junction down there. So for him, I actually sent him to see a pediatric neurosurgeon because I didn't know what to do with it. And they essentially said, there's nothing to do, you're fine, his symptoms are likely because of chronic strain and sprain injury with spasm, so continue with physical therapy and modalities and all those kinds of things. But he continued to have pretty severe pain, and he was still unable to sleep. Over the next 4 weeks, we tried massage, stretching, trigger points, pain creams, and things got a little bit better, but he was still, only sleeping 5 to 6 hours a night. This was better than when I initially saw him when he wasn't sleeping at all, but he wasn't able to do any exercise. And so for me, at this point, I was like, maybe, I'm missing something. So I referred him to see a sports medicine physiatrist to see if they had any thoughts on why he wasn't really getting better. And so I'll get back to kind of what happened with him. As far as the thoracic spine, most of these injuries are going to be the musculoligamentous sprains and strains, especially if you have sports where you're doing a lot of twisting, and then obviously the contact sports. Fractures in this region are usually pretty severe and debilitating, and those are kind of handled sort of separate. But high-speed sports, skiing, snowboarding, cycling is where you see things like that. Obviously, contact sports like football and rugby. And then with the repetitive sports, it's going to be sort of stress injuries and stress fractures. The anatomy, obviously the thoracic spine is where the ribs attach, so there's less range of motion and more more stability in that region. The thoracolumbar junction is where we'll see a lot of injuries because of the transitioning of the orientation of the facets in that region, where you go from sort of twisting motions to flexion and extension. And so with musculoligamentous injuries, these are typically going to be, you have normal neurologic exam, imaging is negative, and it's really just time resting from sport, and then modalities and rehab. Symptoms are what essentially determine when these athletes go back to play. If they're pain-free or close to pain-free and have normal range of motion, and they can tolerate some of that pain, they're back to play. For fractures, if it's a traumatic fracture, most of the time these are essentially career-ending, depending on what's involved and whether they're stable or unstable. They usually need surgery, and these are, usually career-ending. The stress fractures, spondies, these are going to be treated with rest. The issue with these a lot of times is compliance. A whole nother sort of controversial discussion is whether or not to brace these and how long they should be out for and that sort of thing, which I'm not really going to get into. Again, with an abnormal MRI, expert opinion, if the lesions are benign, the recommendations from this group is essentially have them see a surgeon. If the surgeon doesn't think there's anything to do and thinks it's fine, then you have them rehab and they can return to play once they're essentially pain-free and have normal range of motion. So with this kid, just like with the previous one, they never made that appointment to see the sports medicine physiatrist, and then they just stopped coming. And so again, I called his mom last week, and she said that after they last saw me, he basically kept doing what he was doing, and things got better after around a month. He basically decided that football and wrestling weren't worth the pain that he was dealing with. Apparently before the back issues, he'd also had a concussion the year before, and so he essentially just retired from contact sports and just kind of runs and exercises now. The last case is a college athlete. He's a male basketball player that I started seeing in the fall. He presented actually in the training room with 4 out of 10 progressive worsening pain, and then left leg weakness with constant numbness and tingling down to the calf. His symptoms improved with adjustments and ice. He had limited range of motion on exam. He had positive straight leg raise, both seated and supine, in the office. He was a junior college transfer. He had 2 years of eligibility remaining. The first game was in 2 weeks after from when I first saw him. And it's an NAIA school, and so essentially if he plays in 4 games, he's ineligible to redshirt, and that is a year of his eligibility when he only had 2 left. So the initial plan was we got an MRI, we put him on some prednisone, and said no basketball activity until your symptoms improve, and we kind of figure out everything that's going on. So this is his MRI. He ended up having an L5-S1 protrusion that was causing impingement on the left S1 nerve root, but then he also had this incidental lesion that was seen at the left L1 pedicle, measuring 23 millimeters in maximal dimension, and the recommendation was to get a CT scan to sort of better clarify what that was. So then we got a CT scan, and this is that. Essentially, they read it as a non-aggressive medullary lytic lesion in the left L1 pedicle. The differential was an atypical hemangioma, prominent venous lake, even though an early chondroblastoma was a possibility. So essentially, their recommendation was just get another set of imaging in 6 months. And so this is now sort of in the context of we have to decide whether or not this is going to be a year where he can play. He's still having symptoms. We've had sort of these, interesting findings, if you will, that may or may not be important. And so we had him get an epidural injection. He did physical therapy. He didn't want any oral medications. And so at this point, he'd now missed 7 of the 28 games, and he was like, what should I do? How long will I be out? When will I be able to come back? Should I have surgery? Would that allow me to come back sooner? Should I go ahead and redshirt? And then also he was from out of town, and things weren't really going so well with him in school. So with low back pain, 5 to 8% of sports injuries, again, that thoracolumbar region is the highest risk of injury just because of that transition. And the anatomy, again, the posterior longitudinal ligament is weaker than the anterior, so these herniations are, going to be posterior most of the time, except for in trauma. And then impingement on the nerve roots because of where these nerves are in the inferior border of the pedicle, you'll have that impingement on that lower nerve root. For non-surgical treatment, physical therapy, exercises, modalities, massage, myofascial release, most of these conditions will get better with that. Surgical indications, obviously, if someone has cauda equina or bowel or bladder issues, these are emergencies that need to be corrected. Otherwise, if patients fail conservative therapy, then the most common procedures, simple open discectomies, discectomy plus fusion, microdiscectomy is sort of, in my mind, what's most commonly done. I don't know if people are really doing chemonucleolysis. Then you have percutaneous discectomy that people are doing as well. In looking at return to play with conservative treatment, this was a study out of Japan by Iwamoto. They basically looked at essentially 100 athletes by the time they were done, starting from 1993 to 2009. The mean age was 23. They'd all had lumbar disc herniations on MRI. They divided them into their level of sport, and they only included level 3 or level 4 athletes. So these were athletes that were either high recreation and on a high school team, or they were competitive professional or college athletes. Sort of recreational athletes were not included. And then they looked at symptom severity, 0 being no symptoms, 1 being some mild symptoms after sports, 2 being mild symptoms during sports, 3 being severe symptoms that caused them to stop, and then 4 being severe symptoms that didn't allow them to even begin sport. Successful return to play was basically that they were able to get back to the level that they were at before they had the herniation, and this was also based on the decision of the athlete, their trainers, and their coaches and managers. Their conservative protocol was essentially rest. You discontinue the sport until your symptoms are improved by 80% subjectively. Some of them had oral medications, some did not. And then they were basically started on rehab that was based on the sport that they were playing. So each athlete had a different rehabilitation protocol that was geared towards their sport. They did not receive any injections. And basically, out of their 100 athletes, 21% were able to return to play or were not able to return to play because their symptoms never improved. 79% went back to play. 62.8% had subjective improvement in their pain. The highest group where there was improvement was in the leg symptoms, and then the least was in the neurological deficit. The average time of return to play was 4.8 months, with a minimum of 1 month and a maximum of 12 months. They also looked at what were the factors that sort of were significant in addressing this, and the only one was severity level of their symptoms. And then in comparing to surgical treatment, the same group looked, essentially it was a literature review, but from 1990 to 2009, where they found 7 studies that sort of looked at this. 3 of the studies, they looked at microdiscectomy, 3 looked at percutaneous discectomy. There were no open studies, no percutaneous laser, and no endoscopic surgeries in looking at this. And this table on the right shows essentially the average time of return to play with each of these different surgical techniques and compare that to conservative. There's not a lot of, the N in these studies isn't very high, especially in the percutaneous discectomy studies. And those numbers are really kind of all over the place from 1.5 months to 12 months. And so I'm not really sure what to make of this data. Their conclusions were essentially that microdiscectomy and conservative care were not dissimilar, and that percutaneous discectomy and conservative care were dissimilar. And so in clinical practice and speaking to an athlete, essentially it's, I'm not really sure what would get you back faster. If you're not improving, I think surgery is something that needs to be looked at. And in my opinion, it really is based on the surgeon's preference and what they're comfortable doing and, what they've been doing a lot of. But this is sort of the data that's out there in answering this specific question. So with him, like with my other cases, he was a transfer from Arizona, and he essentially just disappeared. We made referrals. I had worked with a lot of the surgeons at Barrows in Phoenix, and so we got him set up to see one of their neurosurgeons as well as one of their sports medicine physiatrists. And at our last appointment, he just basically said, I'm not coming back. And he was going to take online classes in Phoenix. And I haven't been able to get a hold of him, so I'm not really sure what has happened. And so for me, the way I look at return to play with spinal conditions is that really it has to do with each individual athlete, what their goals are, and how severe their injury is what will determine whether or not they come back and how quickly they can come back. This is actually in a lot of severe injuries in sports, and looking specifically like ACL injuries with surgical repair, there are studies that show the main factors for return to play are the athlete's motivation and their sort of behavioral health issues. There's a lot of anxiety, depression that goes along with being injured and being out for an extended period of time. And those are actually what matter. And so for me, when I talk to athletes now, I'm asking them questions like, how badly do you want to play? What are some of the surrounding factors in their life? I think we see this a lot in work injuries with people with spine injuries, where them getting back to work, you can do the greatest surgery in the world, you can have the best treatment and rehab, but if they really aren't motivated to go back, they're just not going to go back. And so that's really the discussion I've started having with athletes that have spinal injuries that are in that kind of gray area.
Right.
So that's it.
Thank you. So a little bit over time, but great, very thought-provoking and insightful talk, especially the aspect of the psychological and the bureaucratic or administrative elements are very important. One very important thing for me that I see quite a lot is these, especially line backers with very tight stenosis that have stingers and burners. First of all, briefly maybe, what's a stinger versus a burner versus a true radiculopathy? And secondly, what do we do with these people who have an acquired stenosis where there's literally no CSF space around and assume they're not myelopathic? Can they actually play, or should we just say, look, your torque ratio is so off, I just in good faith can't let you go back? So, it's a two-folded question. Stingers, burners, radiculopathy, quickly, and then this tight neck, just with neck pain, no neurology.
Okay, so stingers and burners is essentially a transient either stretching or compressing of the brachial plexus. These are injuries where if someone is, the way I look at it is someone just takes your head and shoulder and separates them and stretches the nerves. Those will heal. It just takes time. Whereas a radiculopathy is a compression or damage to the nerve where signal is not normally passing through. And that is something where if you don't remove the offending obstruction, it's just not going to get better. The burners and stingers should get better if you have multiple of these, and this is where sort of the expert opinion comes in, where if you have 3 or more, the thought is that the damage is to the point where now you're putting yourself at risk to have that catastrophic injury. The second part of your question was the tight stenosis.
Tight stenosis comes all the time, these, especially linebackers.
Yeah, and so these are the questions where, again, how important is it for that athlete to participate in sports? For me, with pediatric athletes, if you're a high school athlete and you're in a situation where football isn't, or contact sports aren't keeping you off the streets or something like that, it might be worth playing to get you to college, get a better life, or maybe think about switching positions if you can. If that's not your situation and you're sort of playing because you really like football, but you have other things going on, I mean, at any moment you could have a hit where, you're rendered a quadriplegic. And I think those athletes have to know that. And again, we're dealing a lot of times with teenagers, and the sort of concept of mortality and that sort of thing is just doesn't even come on their radar. I think that's sort of an informed consent decision with the parents and the coaches saying that the type of spine you have, you've gotten away with it for now, but it might be a good idea to see if we can switch you to a different position if you really want to play football or consider another sport.
No, great answer. Any other urgent questions? Otherwise, a little bit over time. Thank you, Bim, for coming back again.
Thank
Hope
you,
to see
guys.
Many times.